Good morning, everybody. I'm so happy to be here today, and thank you for the invitation for today. And we have also some friends in the room. So, first of all, I'm not a specialist in radiology or in imaging. I'm an orthopedics, so I try to transfer to report my point of view, my personal point of view. I'm not a diplomate in radiology. I use radiology and CBCT in my practice. This is my experience. Okay, at the moment I have no publication in this field, but I try to discuss with you my point of view for orthopedic. Okay, first of all, oh, doesn't work. Okay, this is the orthovet clinic 15 days ago. And the problem is that Imaginalis is the guilty. Okay? And I explain to you why Imaginalis is the guilty at the end of my presentation. Okay? Now it's a little bit better. I think that we'll finish the next 10 days. Okay? Okay. Imaging in orthopedic. We use imaging, so X-ray, CT scan, or CBCT for diagnosis, joint pathologies, bone deformities, and fractures. More or less, this is our field of application. But we use imaging for diagnosis, but also for surgical plan. We plan simple osteotomies, example TPLO, complex osteotomies for bone deformities, joint replacement, for example total hip replacement. It's necessary to plan each single surgery, and we perform surgical plan for complex fracture, for example pelvic fracture and or distal humeral fracture. These are some examples of application of imaging in daily practice. And the first question is why orthopedists love standard X-ray? Because I love standard X-ray. I'm a traditional man in this field. Until 1 year ago, I didn't want to use routinely CT scan. But 1 year ago, I changed completely my point of view using CBCT. I discovered CBCT before to meet Imaginalis because my son Federico had a problem in the jaw, in the teeth. And during a hospital consultation, the doctor explained me, it's necessary a high-resolution CT scan. And I thought, what is a high-resolution CT scan? It's a CBCT. Okay? So in human medicine, they consider high-resolution CT scan for the skull, for the jaw, for the teeth, not a standard CT scan, but a CBCT. So they call high-resolution CT scan in this field of medical or surgical approach. So I love X-ray. Why? I try to understand. Because most of the time, traditional radiology provides an extended and immediate overview. We need an overview of our patient. We need not only a small detail. I need to see all the elbow, all the antebrachium, all the humerus. I don't want to see only a small detail. I don't like to see only the CT scan. I want to see before an X-ray. I want to see all the room, similar to, and then I want to discuss with you. But I don't want to only discuss with you. I want to discuss with all the people in the room. So I need an overview, and then I need to focus in a single place. This is my first evaluation. The second evaluation is that orthopedics loves or want or prefer to perform personally X-rays. We don't like to send our patient away for X-rays or for CT scan, because we want to perform X-rays, we want to perform CT scan, and we need to evaluate immediately, not the day after. I want to perform an X-ray, I check, it's okay, I modify the projection, because I want to understand. My diagnosis is a clinical and imaging diagnosis, but in the same moment, not in the different days. So I want to perform clinical examination, X-rays, and if I need a CT scan, I would like to perform immediately a CT scan, not the day after. And so clinical examination and imaging for us are a single process. It's not different process. And at the least, in my experience, traditional CT scan do not always provide fantastic picture images for orthopedics. Sometimes we have experience with bad quality or bad details or not so beautiful details in a standard CT scan. Could be that the machine is an older machine or something like this, I don't know, but can happen. I receive so many clients with CD, with a bad quality CT scan. So, in my opinion, limitation for a traditional CT scan, from my orthopedic point of view, are that the details are not always up to par for joint pathologies. For elbow, carpal, or distal extremities, most of the time, a standard CT is not so perfect for the quality. It is, in my opinion, very operator dependent. The result is operator dependent. It means that it's not enough to put the dog in the CT scan. It's necessary to put the dog in a specific position to study a specific pathology. This is my approach. You cannot put the dog inside and to take a big picture, a total body picture for elbow lameness. It's not a real sensate approach. And sometimes 3D reconstruction are with significant surface artifact. With a spiral CT scan, sometimes we see this type of artifact on the bone surface, and I don't like it. Okay? I'm sorry if it's not everything true, but this is my opinion. Okay? This is my point of view. It's my story, my experience.
Yes, the black book.
No, okay. So, details. This is a standard. I collect from my PC some picture. I don't know. But this is a traditional CT scan. The quality for me is not enough. I can't see in a real way the bone trabecule in this CT scan. This is my picture of a cone-beam scan with a standard definition. It's better. And this is the higher definition of a CT scan. It's much, much, much better. Okay? I don't know if it's true. This is my feeling. Okay? This is true, for sure. Okay? Another elbow. This is an elbow with a standard or traditional CT scan. The quality for me is not good. Could be an old CT scan or a low quality is not the best CT scan in the world, I can imagine. What about details? This is a standard CT scan and this is a CBCT. I want to see this perfectly, a small detail. is not enough for me, this picture. And a CT scan picture or images should be better than an X-ray. This is another stupid approach, but it's true. This is a good X-ray. This is the CT scan. I prefer this X-ray. It's the same case. Okay? But if I have this, and if I have this picture doesn't add anything for me. So what do we need? A friendly system that can be used directly by the orthopedics. I want to perform clinical examination, X-ray, and immediately, if it's necessary, I want to do a CT scan. I do it, or my staff, but immediately. I want a system that can be integrated in the orthopedics daily workflow. I want a system that allows a quick image capture. I don't want to invest 1 hour for CT scan. Should be really quick, 15, 20 minutes. This is my time. I need high image quality in small details, and I need good quality in extended acquisition for the study of bone deformities. One limitation in the past of CBCT was that it was possible to acquire only a small part of the body, so 30 centimeters or no more. Today it's possible to collect more and more, 1 meter, so no problem of limitation about this. What about specific feeling in patient positioning in our practice? We put all the dogs in dorsal recumbency at the moment. Consider that we perform at the moment only CBCT in orthopedics, nothing more. So we put the dog in dorsal recumbency with extended limbs, front or rear limbs in extended position with a support under the limbs, and we press, we lock the limb on this support because we want to limit tremors during the acquisition. Consider that most of the time we don't have the dog in general anesthesia. This is our standard approach. Sedation and a little bit of propofol for 5 minutes. No more. There is not oral, there is not intubation because it's not. I'm not sure that is correct, but it's our approach. So when the legs are too close, we insert some soft water or I don't know the material of this foam in between in order to separate and to limitate artifact, because if you have bone-to-bone contact, you can create more artifact. We tested also sternal recumbency, but in our experience it is not very effective, also because the center of the gantry sometimes is not so near to the legs in this position. So I think that dorsal recumbency is much better, as you can see in these two pictures. So I discuss with you about some pictured cases. Stifle OCD is one of the problems in which we love CBCT. You can see a big hole in this condyle and the really good quality of the detail. We use, so in these cases, we acquire the picture with a higher quality of the, so there is a set for the best quality as possible in the machine. When we need a study for limb alignment, for patellar luxation or bone deformities. We reduce the quality in order to have a quicker acquisition of more bones in the same moment. Why we do it? Because we want to have a complete acquisition of femur, tibia in these cases, to perform measurements and preoperative planning. I don't go in deep in this. In order to measure, to plan, and to have a good idea for our surgery. As I explained before, we use also CBCT in some specific cases for an in-depth fractures evaluation and planning. This is an example. It's a complex fracture of the ilium and a sacroiliac dislocation. And from these X-rays, I'm not sure about the involvement of the acetabulum. And I need to know, because is articular or not, this fracture? So I plan on my CBCT, I can measure the length of the screw to stabilize the sacroiliac joint, and I can reconstruct and I can see inside in order to understand if the acetabulum is involved or not. And just to explain the end, this is the treatment. There was not an involvement of the acetabulum, but a dorsal slab there was, so I reconstruct in this way. Another interesting case, this is a small dog, a poodle, with a cystic lesion of the patella. In these cases, I think that CBCT could be useful in order to understand a little bit better. Trauma in athletes. This is an athlete dog with a small fracture in this area. Could be more or less here, avulsion fracture of a tarsal extensor retinaculum, I think, or something like this. Is, I think, rare as lesion. Obviously in elbow dysplasia. And I like to use in case in which it's necessary to discriminate between elbow dysplasia and other pathologies. In this case, for example, there is an avulsion fracture of extensor, the insertion of extensor tendons. It's not an elbow dysplasia, can be confused. And I like in the last month arthrography. We started with this. I have no great experience, but I love it. In the stifle, we started because I think that it's possible to see cranial cruciate ligament disease. It's possible to see meniscus, cartilage. It's necessary to study, necessary to apply it. I transfer to you some example. You see this structure? This is the caudal cruciate ligament, and this is the cranial one. This caudal and cranial. And it's possible also to see medial and lateral meniscus. This is the medial meniscus. This is the lateral one, in this way. And why not? It's possible to see also the cartilage integrity, the thickness of the cartilage in specific area. I didn't perform a study. It's a clinical approach, and I try to understand in this moment. And now I have a question for imaging specialists. Can pneumoarthrography make sense to visualize cartilage on CT? I don't know, because I have an ancient experience with pneumoarthrography in radiology. I think 20 years ago I did some cases with air in the joint. But I think that it's possible to see cartilage. Why not? I don't know what happened. We can try. Okay, it's a question for you. So why is Imaginalis the guilty? And why we completely renovate the clinic? Now I'm trying to explain why. Okay? So it's not completely guilty. It's a good stress for renovate. Okay?
Yes, it's concrete. No?
Yeah. So, because we want to have a CT room in a diagnostic configuration, but we want to move the machine from the CT room to the surgery room, from this door, because we want to use the machine also during the surgery for fluoroscopy, but also for navigation. So we want double configuration, a diagnostic configuration and a surgical configuration. And for this reason, we renovate, not only for this reason, but during the project, we considered to renovate also this approach. So our old workflow in orthopedic was this, clinical examination and X-rays, standard X-rays, a lot of radiographic projections, and CT scan only for special cases. Now, I think that our approach is modified, is a little bit different. Clinical examination, basic radiographic examination. We try to limit number of X-ray projection to the strictly necessary, and if we want to see something more, we perform immediately a CBCT. And at the end, surgical navigation, and I explain to you in my second presentation. Thank you. Yeah.
Dr. Martini, your images are excellent. What resolution are you shooting?
I don't know. I need to ask my technicians because she did it.
Excellent. Okay. Is it 300 microns or 100 microns that you're shooting it at?
No, okay. 150.
150, thank you.
Okay.
Excellent.
Scusami. But it's true. She is best than me in doing the set and the operative of a machine. So I learned, but now she is best than me. It's true.
Don't you have any artifacts of the skull when you put them on
No.
the back for the... No?
Yeah. No, it was my thought before. If I put elbow near to a skull, something can happen with artifact. The evidence is no. We don't have any artifact. I know I don't have any experience with thorax or abdomen or a little bit on spine, only because sometimes we do also spine for lumbosacral instability or something like this. But for bones, there is no artifact. Okay? Yeah?
Do you perform dynamic study of lumbosacral disease?
No, at the moment, no. I would like to do it in the future, but we started only with orthopedic and basic evaluation for lumbosacral disease. Yeah.
For the forelimbs, are you extending both limbs? Are you putting both limbs forwards or just one?
It depends. Yeah? Grazie. It depends. If I want to see only one limb, I prefer to isolate one single limb. But if I want to see both, I do both. In the same scan. Okay. If I can, I prefer to isolate the limb.
Because like in CT, there was this rumor that you have to put.
Yep.
So from the radiologic point of view, like there were so many colleagues that they want to do like the elbow dysplasia in CT, that they put the one forelimb and they take the head out to reduce the artifact, but it's not true because you consider that CT wants photons. So if you put like a small area of interest, you don't have enough photons. So everything is about how many kV or MIS do you put and how you position the dog. So I disagree with some colleagues that they lose a lot of time, losing time. Also with SCBCT for the elbow, usually I put like in sternal or dorsal recumbency, but I put both forelimbs and the head inside, because sometimes you can see also information from the cervical spine, so everything has to be aligned, and we don't have an amount of artifact that reduce the image quality. So there's no issue. You're losing time. So if you put like in dorsal or sternal recumbency, both forelimbs, you are fast and effective.
Thank you.